So I have been designated as the next speaker, and my remit was how to manage side effects of JAK2 inhibitors in clinical practice. And I'm going to try and give you some practical questions that come, or answers to, perhaps that come up to issues in clinical practice. Most of this will be, of course, about ruxolitinib, because this is the drug that's available and in clinical practice, although I will mention a little bit about the end of some of the other drugs. Those are my disclosures. So whenever we talk about side effects in any of these trials, you get a list of all these different side effects which appear in at least 10% of patients. And this is, of course, what you get in, when you do a trial. The patients report everything. But not much of this really makes any particular difference from a practical point of view. Similarly, you can get this type of picture where you get a number of different side effects occurring, both grade 3 and 4 and all grades. And perhaps some of them you might draw out a little further, diarrhea, but there's no real specific need to look at how to manage this further. Most patients tolerate it and feel so much better on the ruxolitinib. Pain in the extremities and headache are also reported. What we perhaps really want to look about are some of the hematological side effects which occur. And here, again, this is Comfort 1, but you get a similar picture across these studies where you see that on ruxolitinib compared to placebo, you get more grade 3-4 anemia over time. And this is a particular issue. This picture shows the type of what happens where when you start patients on these drugs, they get a fall in their hemoglobin, and then it tends to come up a little bit and plateau off, but obviously not at baseline. So the management of anemia is a difficulty, and after all, these are patients with Mylofibrosis, where anemia is often particularly the issue from them from a clinical point of view. So again, looking at this is looking still at Comfort 1. You can see, compared to best available therapy, more patients get transfused, but about the same amount of transfusion. So what can you do about the anemia? How can you manage this? Well, the first thing is definitely to watch and wait, because you could see from the graph that the hemoglobin dropped, but quite often comes up a bit before it plateaus. Transfusions, obviously, and I've seen patients who hadn't been transfused, and even though they feel much better on these drugs and get a reduction in their splenomegaly, they do start to need transfusion. And then the question comes about the erythropoietic stimulating agents, or EPO, and its related compounds. Now, counterintuitively, you would think that these drugs would be of no use to patients on a JAK inhibitor, because if you're inhibiting the JAK-STAT pathway below the level of where EPO binds with its receptor, then why would giving EPO be of any use to these patients? And in fact, in the Comfort trials, it was specifically forbidden to give erythropoietic stimulating agents as well as the trial drug. Despite that, doctors being doctors, a number of people actually ignored that, and it became obvious that there were a number of patients who were given erythropoietic stimulating agents while in the Comfort trials. So we actually looked at that to see if we could get any feel of how these patients did and if it was of any use. So 13 of the 146 patients in Comfort 2 were given these agents. The bottom line was, when looking at that compared to the rest, is that it seemed to be safe, that there was no increase in splenomegaly, or there were no increased events in this group compared to the others, and there were no more adverse events. Did it do much good for the anemia? Well, perhaps a little in some. The anemia improved to grade 2 in 7 out of the 13. The rate of transfusions remained the same in 1, decreased in 2, so there's perhaps some benefit, increased in 3, but 7 remained transfusion independent. So the bottom line, it's well tolerated. So even though it was counterintuitive, you may not want to do it, it does seem to be well tolerated. It did not affect the efficacy of ruxolitinib, and perhaps there may therefore be some argument that in patients who are anemic, it might be worth a try. I personally would be very keen to know an EPO level before I would give anybody these agents, but it might be of use. The next side effect I would like to point out to you and how you manage it, because I think it's quite alarming when you start a patient on ruxolitinib, is the elevations in the white cell count. Now, this is a patient of mine, and here you have the white cell count, and about here they start their drug. And you can see over the next couple of weeks that quite a high white cell count to start with, but very often patients get these alarming rises in white cell count as soon as they start on the drug. Their white cell count can double or triple. It looks like they have gone into some sort of an acute phase. If you look at the blood film, you can see lots of blasts and things like that. But in fact, if you watch, wait, and hold your nerve, it all tends to settle down again. And you can see here it's settling down, and then the dose was reduced and it went right down. So from the point of view of clinical management of side effects, hold your nerve when you see the white cell count going up like this at the beginning. What about the platelet counts? Well, again, these are some results from COMFORT-I, showing that in the patients on ruxolitinib, the platelet count can drop, particularly at the beginning, and then tends to stabilize out, but can often be lower. So how can you manage this? Well, there are specific rules for dose reduction, and I'm going to show you quite a lot of the dose reduction type rules in a minute. You can watch and wait and see what happens, because it hopefully will stabilize. Obviously, if they have a clinical indication, they may need platelet transfusions. Now, there are quite specific rules for the platelet count and doses of ruxolitinib. The starting dose of ruxolitinib with a normal platelet count is 20 milligrams twice a day, and the maximum dose then, depending on the response, can go up to 25 milligrams twice a day. But there are instructions for lower doses depending on the platelet count. And obviously, the platelet count is supposed to be over 50 before you consider giving these drugs to patients. There is an issue if you have a patient with a platelet count at the lower end, around about 50 or perhaps slightly below, because many of us know from clinical experience that if you actually start them on the drug, often as the spleen shrinks, perhaps you can almost envisage the platelets being squeezed out of the spleen, the platelet count will come up a little bit. And often if you get a good response, then from the drug, you will find that the platelet count goes up. So there is an issue around that, not quite what it says on the SPC, but everybody knows that clinically. And certainly if you have commissioners like mine that want to know why you're giving any of these expensive drugs, there's a temptation if the platelet count is slightly under 50 just to sort of massage it up a little bit so that you can get them started on the drug. But obviously you need to watch the dose very carefully. There are further, and we're not going to read all this out, but there are further complicated modifications for thrombocytopenia depending on with the very low, if the platelet count drops after the start of treatment, where you have to reduce the dose, and you can reduce it slightly less if the decline isn't too fast than if the decline is greater than 20%. But basically all of these go around reducing the dose, but trying to maintain patients even on very low doses, as little as 5 milligrams once a day, and then hoping that as the platelet count improves, you may be able to get that back up again. So talking about the platelet count then brings in the next factor of bleeding, and certainly on these the drugs, there is a bleeding risk, and there are reports of increased bleeding incidences. You can produce this sort of table of all the different things that increase the risk of bleeding in the host, prior history, the disease itself, and obviously ongoing therapy. And as a clinician, you have to try and make some sort of an assessment of the bleeding risk and decide what is the best to do for the patient to minimize the risk. Is it a better option to put them on the drugs or not, depending on their bleeding risk? If they do get bleeding, what is the advice? Well, the advice is you must interrupt treatment for the required intervention, whatever the cause of the bleeding is, regardless of the platelet count. If it's resolved, then you could consider resuming at a prior dose if the bleeding is controlled. And if the bleeding is resolved but the underlying cause persists, then you should consider resuming the ruxolitinib at a lower dose. A lot of this then brings in the fact that with all these dose reductions, patients end up on low doses, long-term, 5 milligrams twice a day. And I think you have to make a point about this, that the long-term low dose has not actually been shown to have particular responses. That's the advice in the SPC, what you're specifically told. However, I'm sure many people are aware, and I certainly can think of patients who felt so much better, even on a very low dose. And I think you have to continue use if you feel that the benefit outweighs the risks. And certainly in my clinical experience, it's the patient who gets a huge symptomatic improvement, even on a very low dose, that almost beg you to keep them on the drug. But I think you have to keep that in mind. But on the other hand, if there's no spleen size reduction and no symptom improvement, then I think you have to ask yourself what's the point of having patients on low doses. Interactions then, I think this is very important. Ruxolitinib is metabolized by the ubiquitous CYP3A4 and to a lesser extent CYP2C9 pathways. Therefore, strong CYP3A inhibitors increase the drug level and increase the area under the curve. So you need to be aware of this. This is supposed to be grapefruit juice. Grapefruit juice is the notorious one that you have to tell people not to take their drugs with because it's a CYP3A4 inhibitor. I think caffeine sometimes comes in there as well, although I always remember the patient who came and told me after 4 years, could they please have a cup of coffee because somebody had mentioned coffee and they'd never ever touched it again. So you do have to be careful. It's really just when you're taking the tablets. There are other drugs, fluconazole is mentioned, but there are obviously a list of these drugs that you have to be aware of, that they can increase the area under the curve, so that needs care. So specifically then, looking at renal impairment, is there any advice or anything you need to do to manage renal impairment? The advice is that if it's moderate or severe renal impairment, then again, what you need to do depends on the platelet count. If the platelet count is greater than 150, you don't need to do anything. With lower levels, then you need to reduce the dose. If the patient is on dialysis, there's specific instructions in the SPC that suggest how you might be able to manage that and give at least some doses of the drugs. The other one is hepatic impairment. What I did when I prepared this slide, this was the first set of information I got, which said moderate or severe, mild, moderate, severe hepatic impairment. If the platelets were greater than 150, no dose modification. Otherwise, with the lowest platelet count, lower platelet count, you do need dose modification. Interestingly, there's two different versions of this. This is actually the US Novartis stuff. When you look at the EMC advice from the European Medicines Agency, they've actually said that anybody with hepatic impairment should have a 50% reduction in the dose. But I suspect there's no great difference in this because there's not too many people with hepatic impairment who are going to have a platelet count over 150 anyway. So I think it's much of a muchness. The point is that you need to think about it and probably reduce the dose. What about infections and the management of infections in patients receiving ruxolitinib? Well, this has been quite an issue. There have been low but consistent rates of infections reported across the COMFORT studies, and there are a number of other probably quite alarming infections that have been seen in individual reports subsequently. Cryptococcus neoformans, this case of progressive multifocal leukoencephalopathy, which I'll mention again in a minute, and 2 cases of TB adenitis in areas where TB would have been endemic. There's certainly an increase of minor infections across the patients treated with ruxolitinib, urinary tract infections, and reactivation of herpes. And I would say from a clinical practice point of view, it's reactivation of herpes, herpes zoster that we are seeing. There was this one case in the UK of a patient who developed within a few weeks of starting ruxolitinib progressive multifocal leukoencephalopathy. And I certainly have heard extensive details of this patient, and it is really quite alarming, and it's clearly proven when the drug was withdrawn, the patient actually went to a hospice, and then they actually improved after the drug was withdrawn. So thankfully, there hasn't been any more of that, but it is something you need to be very aware of. What can you do? How do you manage these infections? Well, tuberculosis first. I think you have to evaluate tuberculosis risk factors prior to initiation of ruxolitinib and test those at high risk for any signs of tuberculosis. And obviously, that is a big issue. I live in an area where nobody has tuberculosis, but they all did 40 years ago, if you look hard enough. So you need to be aware of that. If there is active or latent tuberculosis, my advice would be consult a physician with expertise in the treatment of tuberculosis, because I don't think as haematologists we have enough expertise to decide on that ourselves. And we see this with AML patients as well, whose lesion is such that they actually need to go on some treatment. And there may be an issue as starting people on rifampicin if they are going on ruxolitinib, but I think that's one for advice with an expert in tuberculosis. So it overall depends on the risk-benefit analysis in somebody who has active tuberculosis. Other infections, what advice can we give? Herpes zoster, I think people are becoming more and more aware of. Advise the patients about early symptoms and signs, and if it's suspected, seek treatment as early as possible. If they've already had a reactivation with herpes zoster, then there's a question, would you want to put these patients on secondary prophylaxis? Hepatitis B, the advice now is that all patients should be screened for hepatitis B before starting treatment. The effect of ruxolitinib on viral replication is unknown, but patients with chronic hepatitis should be treated and monitored according to the clinical guidelines. And obviously there are some areas where hepatitis B is a much bigger issue than others. And then the progressive multifocal leukoencephalopathy, if suspected, stop the ruxolitinib and evaluate. And that is looking for any cognitive, neurological, or psychiatric symptoms or signs. And the patients may not be aware of this. This is not the sort of thing that patient may particularly report if they're old and they've just had noticed some difference. So I think as clinicians, we need to be alert to this. Another reported side effect that I think we need to think about is there has been an increased report of non-melanoma skin cancer in patients on ruxolitinib. There's all sorts of issues about this. Many of these patients have had many other prior treatments before they go on ruxolitinib, but it is reported. What can you do about this? And this is, I think, something that we don't do well enough with our patients overall. I think we need to raise patient awareness so that they avoid skin exposure and look at their skin and report anything that appears. And I personally think with other drugs, we don't do that enough. We have farmers who come in who never look at their skin. We've seen far more things in them than in other people. So I think we have to make sure all our patients know things like avoiding skin exposure. What about interrupting therapy? Stopping the treatment, basically. Is this a problem? Well, it was reported in this case where this is a patient who had a decrease in their symptoms, stopped their ruxolitinib, and within 7 days, they got a major increase in their symptomatology. And there have also been a number of reports in this series. 11% of this series, 5 out of 47 in one centre, reported serious adverse events on stopping ruxolitinib. They had a relapse of their symptoms, hemodynamic compensation, a septic shock-like syndrome. And this is referred to as a systemic inflammatory response syndrome, that you get a cytokine storm on stopping the ruxolitinib. However, there were no SAEs reported on drug discontinuation in the 2 COMFORT studies. However, despite that, you need to be aware of this. And what should we do? Well, first of all, instruct the patient not to interrupt or discontinue the drug without consulting the physician. Don't just stop it. If discontinuing or interrupting therapy for reasons other than thrombocytopenia, taper the dose gradually rather than just suddenly stopping. Obviously, with its thrombocytopenia, there may be instances where you have to stop it, but you need to be aware. If major symptoms or signs after discontinuation, obviously evaluate for intercurrent illness and consider restarting or increasing the dose. You may have to actually, even if there's a good reason to start, give a little dose back again. The point I sort of want to make now is about response. We're putting these patients on this drug. What happens to them with time? Eventually, they will lose the response. So this is COMFORT 2 and the duration of the spleen response. It's very good, but over time, patients start to lose the response. These drugs are not curative. Ultimately patients will lose the response. And you can do this sort of picture where someone has looked at the JAK and shows that there are particular mutations that can arise which are activating and resistant. So one can predict it's over time that patients will lose the response. Well, you call that a side effect of treatment, but I think that over time patients will no longer respond, and that will be an issue. So that's lots and lots of things, hopefully of some clinical use in managing JAK inhibitors in clinical practice. There were just a couple of other things I wanted to mention about some of the other drugs at the end and where they may be an issue as well. Some of this Serge has covered from the point of view of the trials, but I did think it's worth mentioning. This is a study of momelotinib, and it's really making the point again that as patients are on this at baseline, these are the ones who are transfusion dependent, and over time the rate of transfusion independence increases, or over the doses. So this is a different drug, and if it, as we've heard already, fulfills its promise, it may be better from the point of view of managing the anemia. The other sort of side effects perhaps worth mentioning is this one consisting about the fedratinib, which, as you know, has been withdrawn. It was actually very useful, and the patients got very good responses to it, but then it's been completely withdrawn because of the encephalopathy, because of the Wernicke's encephalopathy. So there is this issue of encephalopathy with JAK inhibitors. It doesn't appear to be a class effect. However, as we've heard before, it has been reported with this drug, XL109, was withdrawn because of the neurological symptoms. Fedratinib, 8 cases, and you do get some peripheral neuropathy with momelotinib as well. So there is potential all the time for neurological side effects with these drugs, which we need to be aware of. Pacritinib, then finally, again, you have heard about. This has also been withdrawn because of increased bleeding and deaths, and again, it's been investigated further. I understand that they're looking for the results of PERSIST-2 and planning to take this forward, but again, from the point of view of management, the side effects, the bleeding, and whatever the background to this may be an issue in the future. So that's really all I can think of to say. about managing side effects of JAK inhibitors. What are the key messages? Well, certainly cytopenias occur, and I've tried to suggest some ways they can be managed, a lot of which includes dose reduction. Dose reduction may also be advisable for organ impairment. Increased infections occur, and awareness and screening are required. And particularly important, I think, because we didn't know it at the beginning, withdrawal from drug may precipitate recurrence of symptoms and must be managed. Thank you very much.